joined by Dr. Perry Fleisher. How you doing, Doc?
Good morning, Pat. I'm good, thank you.
Is it warmed up a little bit?
It's still pretty chilly.
Is it?
Yeah.
It was really cold this morning at 6:30.
I just got back from Canada, up north of Montreal, and it was 17 below zero.
Woo!
So this is not cold.
This is nothing to you.
Compared to last week for me.
Well, we're supposed to get up towards 60 towards the end of the week, so
Oh,
yeah, that might not be good. I don't know whether that's good or not.
It's
But
going to get muddy.
yeah, it's going to be very muddy and wet and rainy and all that stuff coming up. Of course, Dr. Fleisher is a cardiologist with ACMC. And Doc, we're going to talk today about medical management, I guess, of heart disease.
Yeah, you know, the last few times I've been on, I brought some technology with me. Last time I was here, I think I brought some pacemakers with me, and we talked about some of the rather wonderful procedures and technology that we have available to treat heart disease. And that is, the public is kind of enamored with that, and that's what you hear about in the news, but it's only a small part of what we actually do.
Mm-hmm. Mm-hmm. I just read the other day in a magazine. Now this isn't one of your major magazines, this is one of those scandal sheet things that you get. The Globe, I believe it. They were saying in 2013, I don't know how true this is, but they were showing a pacemaker that was no bigger than the end of this pen.
Mm-hmm.
Is that possible?
There are several devices coming up that in the pacemaker class, and I say that meaning these are electronic devices that are implanted in patients that perform various different functions. Some of them are actual pacemakers, some of them are shocking defibrillators for the patients that need those, and some forms of monitoring that do no pacing or shocking, but actually just monitor rhythms and report, that are miniaturized to the point that in the case of one of the monitors, it actually is injected under the skin through a type of needle and not through an open surgical incision. So yes, we're seeing some devices. Some years ago we talked about a pacemaker that was small enough to be able to be implanted completely within the heart on the end of a catheter. The concerns, I think, back then, and I'm going back more than 10 years when that was conceived of, but then questions started to arise as to, well, all pacemakers have a battery lifespan. I mean, these days it's measured in decades in some cases. We have pacers certainly that go well beyond 10 years, but sooner or later the pacemaker needs to be changed out, and the question then is, do we need to retrieve these devices, and if so, how do you get them out once you put them in, because they're no longer easily accessible from the outside. So there were some concerns, but yes, that degree of miniaturization has been achieved at this point.
I guess since we're talking about medical management, Doc, why is medical management important?
Well, medical management of heart disease, and I know there are various kinds of heart disease, but what we're going to be talking about today predominantly is coronary artery disease, the disease of blockage in the arteries, the blood vessels that feed the heart, that leads to heart attacks. And again, we have all these procedures that we've talked about with open heart surgery and angioplasty with stents and so on, but that really represents a relatively small proportion of what we do. And my day-to-day, the nuts and bolts, if you will, of what cardiology practice is managing the day-to-day treatment of patients with heart disease and using various types of medications to accomplish that. Not everybody gets stents, not everybody gets open heart surgery, and we'll talk about the whys and wheres for that in just a short while. But clearly 80% of what we do as cardiologists involves the prescription and management of medications for this.
Okay. So basically, what you're saying, I guess, in a nutshell, is you can treat heart conditions with medications effectively.
Absolutely.
Is that because of some of the advancements that we have made?
It's due to the advancements that we've made in medications and the advancements that we've made in understanding the nature of the disease itself.
Okay.
Where the disease lives, what it does, and how to treat that. Now what we need to understand is that we're trying to accomplish two goals with all of our treatments, whether the treatment is with medication or whether the treatment is with surgery or stents. We're trying to accomplish, really, when it comes right down to it, just two goals. And the first goal is the prevention of what we would call adverse outcomes, which includes death and disability and so on as pertains to the disease itself. So we want to prevent heart attacks, first off, because heart attacks permanently damage the heart, and they're morbid events. People die from heart attacks, obviously. They die from the consequences of the heart attacks. So preventing a heart attack is very important. That's number one. And then the second thing is relieving symptoms. Letting a person return to normal life, be able to go from day to day and be free of the burden of either shortness of breath or chest pain or fainting spells or what other symptoms might be associated with the disease. And if we understand that those are our two goals, then we need to understand that we have a large number of tools available to us to try to achieve those goals, of which things like open heart surgery and stents are only two. And many of the medications, lifestyle modification, including things like diet, exercise, smoking cessation, all of those things go into the total picture of treating this disease. And it's, as we know, it's a very common disease, the leading cause of death in this country for adults. So these are very important things. And the other thing that we need to understand is that as we've developed technology, in almost every case, going back 40 plus years, as we've developed technologies to treat these diseases, the technology has been, to some extent, always in advance of knowledge. And that is, okay, I've invented a procedure, and it looks like this would be a good procedure. I can put a balloon in an artery and I can squeeze it open. And later we can put a stent to open up the artery. But are we achieving the goals that we're looking for? Are we relieving symptoms? And most importantly, are we preventing heart attacks? Are we improving both the quality as well as the quantity of life that a person is getting by doing the treatment? And the problem is that after you develop a technology, you have to treat a large number of patients for a very long period of time before you can look back and see how effective your treatment was. We don't have a crystal ball. So in the case, for instance, of, let's say, open heart surgery, bypass surgery, we were doing this procedure for upwards of 20 years before we had a really excellent large study that looked at the outcomes to show that, yes, indeed, with open heart surgery, with bypass surgery, we were saving lives, we were prolonging life, and we were improving symptoms. But for the first 15 or 20 years that we were doing it because we had some small evidence that it was a good procedure. It was successful. Patients came back and said they felt better. But in the long run, every individual physician has his own small sample of the entire large public that was being treated with the procedure, and gets an impression. And until you can take all of this and put it together and look at, say, 50,000 patients treated for 10 years,
right,
and look back at those statistics and say, okay, these were the outcomes, and measure those outcomes in an objective way, so that we know people are being improved in some way. And again, in a way that we can measure and set on paper and say, yes, this percent of people lived better than the percent of people that didn't get the treatment. We don't have a good knowledge of. Now, the most important thing to bring out is that, yes, these treatments are open heart surgery, bypass surgery, coronary stents, in the right settings, do achieve the goals that we're talking about. They relieve symptoms, they prevent heart attacks, and thereby they improve both quantity and quality of life. But what we need to understand is that the medications that we have do the same thing in the right circumstances. And so what we come down to is increasing our knowledge over the course of time to understand exactly what type of patient benefits best from which treatment. rather than just jumping in and saying, okay, this person has a narrowing in an artery, let's go fix it. In some cases, that's the wrong answer. And unfortunately, we learn that retrospectively, 5 or 10 years after the treatment has begun. Not in that one patient, but in the population in general. So that's the complex answer to the question, why not just apply all of this technology to everybody? Why not do a bypass operation on everybody that has blockages?
Right, right.
And obviously, surgery has some, every treatment has its downsides. We have side effects from medication. We have bad outcomes with a small portion of surgery, bad outcomes with a small portion of any procedure that we do can have a complication or have an unintended outcome. So,
I was reading a medical study here recently, and two things popped up that I wanted to ask you about. One, it said improper sleep habits are not good for the heart, and the use of salt, of course, that's for I think the end of blood pressure, which leads to heart problems as well. It should be really curtailed. Can you give any comments on that?
sure. In reference to sleep deprivation has, we know, a large array of bad outcomes associated with it, including problems with cardiovascular health, problems with mental health, problems with stamina and digestion and nutrition. And as we look more and more at sleep disturbances, we are beginning to understand just how widespread sleep deprivation is as an underlying cause for a lot of problems. And we live in a society that has moved more and more towards sleep deprivation in general. We have, starting all the way back with the Industrial Revolution and electricity and artificial light giving us a reason to be more active in the later hours of the day. We stay up later and later. We start our days earlier and earlier, and we compress our sleep eventually into smaller and shorter periods of time. And as a society in general, Western civilization probably is sleep deprived to a greater extent now than it has in
Is that right? Wow.
It takes a toll. It takes a toll eventually on that and on all sorts of health-related problems. Obviously, it's one thing if we were staying up later in order to do our daily aerobic exercise. That
right.
But by and large, we're staying up later to watch television. We're staying up later for parties. We're staying up later to finish the paperwork from the office for the day that we didn't get done during the day. I do that.
Yeah.
So
Yeah, I know.
we're not extending the hours of our day using that time to improve our health in a preventative way, and so we're doubly compounding.
Would one of those sleep problems include sleep apnea?
Sleep apnea is, which also is very important in my field, though it's technically a lung problem.
Oh, is it?
I mean, but well, in that the study of sleep disturbances and sleep apnea tends to fall somewhere between the neurologists and the say brain effects, because the sleep deprivation affects the brain, and also the pulmonologists who study the lungs. But the consequences are very important in my field as well, because the abnormalities that occur in physiology from sleep apnea do affect the heart significantly. So I send many patients for sleep studies looking for sleep apnea, and as our society has again increased in weight, and if we go back to last year, if you recall, I did a piece here on obesity,
the
epidemic in this country. Then, which by the way, the newest data shows that now even Colorado is falling into the, if you remember, that was the only state left.
Right.
Obesity is a significant link with obstructive sleep apnea, and although it's not the only link. And so as we've seen obesity increase in our society, we're seeing more and more patients with sleep apnea.
Really?
And that sleep apnea affects heart rhythm. Sleep apnea affects the function primarily the right side of the heart, and eventually the left side of the heart. And so, as I said, as a cardiologist, I see a lot of patients who present to my office with referred because they had shortness of breath or because they had chest pains of one type or another, and we can trace that in part to obstructive sleep apnea.
The other question, salt.
Salt is kind of a variable. We need salt, so it's not poison, obviously.
Right.
But by and large, again, we tend to consume more salt than we need to. Our bodies are very good at conserving salt when it has to. And again, as a Western society, we tend to add more salt to our diet than we really need to.
Yeah.
So as we move toward, again, toward our fast-paced, I don't have enough time to do what I want to do days of lifestyle, we tend to move from cooking with fresh and wholesome foods from scratch, and we switch to going and getting cold cuts and throwing them on a sandwich, or we open up a can of soup or some other canned item. And the canning process for many of these prepared foods and the preservation process for many of the prepared foods adds salt. So we end up consuming a lot more sodium than we need to. Now, by and large, our bodies, when they're healthy, will excrete and eliminate the excess of sodium. But over the course of time, we are genetically pre-programmed, not all of us, but most of us are pre-programmed, that as we get older, we start to retain more salt than we need to. So our blood pressures go up, we develop high blood pressure, and this in fact then, in turn, then affects the heart and the blood vessels, and it increases the rate at which we get coronary artery disease. It increases the rate at which congestive heart failure occurs. So lots and lots of spin-off from that. And decreasing salt intake early in life probably helps prevent some of that. I don't know that there's really good epidemiologic data, or if there is, I'm not aware of it myself, but I certainly would tell people to try to limit their excess salt intake.
I know when I cut back on salt years ago, and you know, you get used to not having salt, salting everything, and now when my wife salts something a little more than she should, I don't like it. You know, you get that way.
Yeah, I find personally taking the salt shaker off the table is a good first start.
Yeah.
There's still a few things that, no matter how much you've gotten away from using salt, there may be one particular food item that you prefer to have with salt on it. That's not going to harm you. This is something you're eating 3 times a day. So, you know, if you want to say, well, you know, I can get rid of the salt and not use it on anything except maybe corn on the cob or something like that.
Oh, there's 3 things. Corn on the cob is one.
That's one.
Green onions and hard-boiled eggs I have salt on. That's it.
Yeah. And obviously that kind of behavior is not going to harm.
Okay.
Because you're eliminating salt.
You know what else I gave up, Doc, too, was canned soup.
Mm-hmm.
And my wife every Sunday makes a fresh, homemade soup.
And that's so much better for you.
It is. It really is.
The canned soups have, now there are some out there that are low salt and salt-free. And from personal experience, I think they lose some flavor.
They do.
So I'm not going to tell you that I never eat those things, but the standard canned soups, it doesn't matter which brand we're talking about, have immense amounts of sodium in them for the amount of nutrition that you're getting from them. So those are things to kind of stay away from.
What are the goals for treatment?
Okay. So as I said, we're looking to prevent heart attacks, and we're looking to relieve symptoms. And in order to do that, we have to understand where this disease comes from. And I think the most important thing to understand is that we have to separate the results of the disease from the disease process itself. And the results of the disease are at the anatomic level, are blockages in the arteries of the heart. And that's what we address with things like stents and bypass surgery. So what we're doing is we are treating and partially correcting the result of the disease, but it's not the disease itself, it's the result that we're treating. In this case, the disease is why the blockage is formed to begin with, the process we call atherogenesis, atherosclerosis, or what people refer to as hardening of the arteries, and the deposition of putting cholesterol into our blood vessels. And that process goes on even after you've corrected the blockages that have already occurred, be it with stents or open heart surgery or whatever. That's not the answer to the disease. That's a treatment of the symptom and the result. But the disease is still there. You still are day to day forming more plaque in the arteries and blocking them. And that has to be addressed, else the fix that you gave is going to be a very temporary fix. Because you fix this narrowing, and a few years later, or less, you've got a new narrowing.
Or less, yeah.
Consequently, we also have to understand, the second thing is that since this disease lives in the lining of the blood vessels, and we can make certain predictions about how a particular abnormality in that blood vessel lining is going to behave itself over the course of time. And so if I have found an artery in the heart that has some narrowing in it, and I determine through the various tests that we do that that narrowing is not likely to go on to cause a heart attack, and that artery is not that narrowing is not likely to cause intractable pain that I can't address in some other way, then the question is, why should I recommend putting a stent in? Why should I recommend doing a procedure that might be harmful, small percentage of complication rate, to try to fix a problem that actually doesn't exist except in our minds, that if there's a narrowing, that's got to be bad. Why not treat that in a way that causes that narrowing hopefully never to get worse, possibly even to get better over the course of time? Prevent it from causing chest pain, prevent it from causing a heart attack, and do this with medication rather than putting in a stent or subjecting somebody to open heart surgery. And what we have to do is be better at, or good at, trying to determine just which narrowings are the ones that we should go after with procedures versus those that we shouldn't. Because we're still going to have to use these medications after we fix the narrowing to prevent new ones. But if our medications are just as good at preventing that narrowing from causing a problem, then why not just treat them with the medication by itself? And it is effective, it does work.
Speaking of medications, what are there new ones out there?
There are some new ones. Many of the medications, fortunately, are old, tried and true friends that we've used for many years, and to the benefit of patients today. These medicines are now old enough that we know, number one, we're very, very intimately familiar with their effects and side effects, so we know that they're safe. They've been out there for 20 or more years.
Yeah.
Their patents, for the most part, have run out, so they're now generic and they're affordable, and that's very important. There's no sense in me prescribing a medication to my patient if they can't afford to obtain it. But what we've learned new over the past 10 to 20 years is that these medicines, is how these medicines work with respect to the arteries of the heart, and how they affect the linings of these arteries. And all of our arteries have a thin layer along their inside. We call it the endothelium. It's a very narrow, very thin layer that for many years we thought, well, this is just like cellophane. It's inert, but it's a living tissue, and it has health and sickness, if you will. And when these linings are sick, that's how we end up getting hardening of the arteries and blockages. And we know which of these medicines improves the health, if you will, of them. So we have several classes of medicines. The beta blockers have been around for, I'm going to say, more than 40 years. Propranolol or Inderal was around first, and now there's probably 30 or or more of them on the market. And those are pretty much the mainstay. Many people are on medicines, they know the names out there like metoprolol or Lopressor or Toprol and so on. These are probably the central theme for much of what we do with heart disease. They tend to reduce blood pressure, they reduce strain on the heart, they slow the heartbeat down so we don't have as much stress on the heart. That helps relieve pain. But most importantly, these medications also tend to improve the blood flow through various different effects on the heart muscle. We also use another of the blood pressure medication classes, the so-called angiotensin-converting enzyme inhibitors, or ACE inhibitors, also a class that's been around for 20 or 30 years and mostly generic. And these directly improve the health of the lining of the blood vessels. And we know now, over the course of many years, these treatments are important not just in relieving symptoms, but they also prevent heart attacks from occurring. Probably the biggest preventative treatment that we do for people is plain simple aspirin at low dose. So-called baby aspirin, 81 milligrams. We know the dosage range somewhere between 50 and 100 milligrams is all that we need to help prevent the blood clot that begins to form, that starts the heart attack process. And for many of our patients, just taking an 81 milligram aspirin daily reduces their risk of a heart attack by more than 30%. So it's inexpensive, it's simple. Now some people can't take it, obviously they're allergic to it, or they have bleeding ulcers or something along those lines. But so again, managing patients, not a matter of taking out the cookbook and just starting to write prescriptions, obviously. But these medicines we have are extremely effective in achieving the two goals that we're looking for: relief of symptoms and prevention of heart attack.
You're based right out of Ashtabula, right? On a daily basis?
Our office is open daily, where Dr. Stevens and I are staff the office full-time. We're both from Cleveland Clinic, but we're stationed out here in Ashtabula at ACMC, and it is a full-time office.
I got a couple buddies that go to you.
Mm-hmm.
High compliments to you. They say you're doing a tremendous job, and
good to hear.
I think a lot of you. A very educational session today. I really appreciate it, Doc. And always look forward to your visits here. You always have a lot of educational things to give us and updates on what's going on out there.
Thank you. I mentioned that we probably only touched on a very edge of the entire breadth of medications. Lots of other medications that we use that I have. Time doesn't permit us to actually go into each and every one of them, but I do go into that discussion with my patients during the prescription processes. So.
Excellent.
You'll hear it here, and if you need it, you'll hear it in my office.
Look forward to seeing you again next month or whenever we get next schedule.